exam-ready version of the Chromosomal Microarray Analysis, CMA, Chromosomal Microarray Analysis, CMA test. 1. Introduction. Genetic disorders are a significant cause of developmental delay, intellectual disability, autism spectrum disorder, congenital malformations, and recurrent pregnancy loss. Traditionally, karyotyping and FISH, fluorescent in situ hybridization, have been used to identify chromosomal abnormalities. However, these methods are limited in resolution. Chromosomal Microarray Analysis, CMA, developed in the late 1990s, provides a high-resolution, genome-wide assessment of chromosomal gains and losses, copy number variations, CNVs. It is now recommended as the first-line genetic test in children with unexplained developmental disabilities or congenital anomalies, according to the American College of Medical Genetics. Top 2. Definition. Chromosomal microarray analysis, CMA, is a molecular cytogenetic technique that allows the detection of submicroscopic chromosomal imbalances across the genome. Unlike karyotyping, which identifies abnormalities 5 to 10 megabaud, CMA can detect CNVs as small as 50 to 100 baud, depending on the platform. 3. Indications. CMA is indicated in neurodevelopmental disorders, autism spectrum disorder, ASD, intellectual disability, ID, developmental delay, DD, congenital anomalies, heart defects, craniofacial abnormalities, limb malformations, etc., dysmorphic features without a known syndrome, unexplained epilepsy or psychiatric disorders, reproductive issues, recurrent pregnancy loss, RPL, infertility evaluation, prenatal diagnosis, abnormal ultrasound findings, e.g., structural anomalies, growth restriction, positive non-invasive prenatal testing, NIPT results, stillbirth evaluation. Used for CMA is mainly used for detection of copy number variations, CNVs, microdeletions, microduplications, unbalanced chromosomal rearrangements, characterizing chromosomal breakpoints and translocations, identifying known pathogenic CNVs linked to genetic syndromes, e.g. DeGeorge syndrome, Prader-Willi syndrome, Williams syndrome. Research purposes, investigating genetic causes of neurodevelopmental and psychiatric disorders. 5. Why do need of this test? Higher sensitivity than karyotyping, detects small changes invisible under a microscope, provides an etiological diagnosis in up to 15 to 20% of children with unexplained intellectual disability developmental delay versus 3% with karyotyping, guides clinical management, prognosis, and treatment planning, facilitates genetic counseling for families, recurrence risk, family planning, useful in prenatal decision-making when anomalies are detected on ultrasound, reduces uncertainty by avoiding multiple unnecessary investigations. Number 6. What happens during test? 1. Sample collection. Peripheral blood most common, saliva or buccal swab. Alternative, amniotic fluid or chorionic villus sample, prenatal cases. Tissue sample, products of conception and miscarriage cases. 2. DNA extraction. DNA is purified from the sample. 3. Microarray hybridization. Patient's DNA is labeled with a fluorescent dye and applied to a microarray chip containing thousands of probes spanning the entire genome. The DNA is compared with a reference DNA sample. 4. Data analysis. Computer software detects gains, duplications, and losses, deletions. The data is analyzed against databases such as ClinVar, Decipher, and DGV, database of genomic variants. 7. How long for my results? Typically 10 to 21 days, 1 to 3 weeks, depending on sample type, blood versus tissue, complexity of results, normal versus uncertain findings, lab workload, and urgency. Prenatal samples may be expedited. 8. Prepare for this test. No fasting or medication changes required for blood saliva samples. For prenatal CMA, procedures like amniocentesis or CVS may require specific pre-test instructions. Patients should provide detailed clinical history, developmental, medical, family pedigree if possible. Informed consent is required because results may reveal incidental findings, e.g. susceptibility to late-onset diseases. 9. Risk to blood sample collection. Minimal risks, mild pain, bruise at needle site. Saliva buccal swab, no risk. Prenatal sampling, CVS amniocentesis. Slight risk of miscarriage, bleeding, or infection, about 0.1–0.3%. Psychological risk, uncertainty and stress if results are inconclusive or reveal unexpected information. NAVR 10 normal values. Normal, negative, CMA result. No pathogenic chromosomal imbalance detected. A normal result indicates the absence of significant CNVs but does not rule out balanced chromosomal rearrangements, single nucleotide variants, point mutations, low-level mosaicism. HAP 11. Interpretation. Results. Normal, no abnormal CNVs detected. Chromosomal structure appears normal. Pathogenic CNVs. Abnormal positive result. Known deletion, duplication associated with a clinical syndrome. Variant of uncertain significance, VUS. Abnormality detected, but its clinical significance is not yet clear. May require parental studies. Likely benign CNV. Variation commonly seen in the general population with no health impact. Incidental findings may reveal unrelated but clinically relevant information, e.g., cancer predisposition genes. 12. Factors affecting results. DNA quality and purity. Degraded DNA may cause errors. Level of mosaicism. Low mosaic states may be missed. Platform resolution. Different chips detect different sizes of CNVs. Parental testing availability. Helps classify variants as inherited or de novo. Database limitations. Some rare CNVs not yet fully understood. To the clinical significance. Diagnostic yield. CMA provides a diagnosis in 15 to 20% of unexplained developmental ID cases. Clinical utility. Confirms a genetic syndrome. Provides prognosis and guides therapy. Helps avoid unnecessary tests. Reproductive counseling. Identifies recurrence risks for future pregnancies. Prenatal relevance. Detects pathogenic CNVs when ultrasound anomalies are present. Psychosocial impact helps families understand the condition and access support networks. 14. No more. CMA versus karyotyping versus FISH. Karyotype detects only large chromosomal abnormalities, 5 to 10 megabads. FISH detects known targeted abnormalities, e.g., Down syndrome, DeGeorge. CMA detects genome-wide small CNVs, much more sensitive. Limitations of CMA. Cannot detect balanced rearrangements, e.g. translocations, inversions, point mutations, single gene changes, mitochondrial DNA abnormalities, future advances, whole exome sequencing, S, and whole genome sequencing, WGS, may complement CMA in diagnosis. Patent 15. Chromosomal Microarray Analysis, CMA, is a powerful first-line genetic test for detecting chromosomal abnormalities with much greater accuracy than traditional methods. It is invaluable in diagnosing unexplained developmental delay, intellectual disability, autism, congenital anomalies, infertility, and pregnancy losses. Although it cannot detect all genetic changes, its high sensitivity, diagnostic yield, and clinical utility make it a cornerstone of modern genetic medicine. CMA not only helps in accurate diagnosis, but also provides vital information for management, prognosis, and genetic counseling. Thank you. Have a nice day.